Hi everyone, this is Christine Johnson, and I'm going to be your instructor for Pediatric Boot Camp. What you should know first about pediatrics, or providing care to pediatrics, is that pediatric patients can be treated for emergencies, and even if they don't have a parent or legal guardian present. So if you have a pediatric patient come into the ER and there's no parent with them, if they are in a life-threatening situation, they can be taken care of without permission. Other than that, though, they need consent from a parent or legal guardian. If you feel at any time that the parent is not making a medical decision that's safe for the child, you can contact law enforcement. Usually there's an ethics committee at the hospital that you work at, and you probably start there. But it's usually a physician's call to make that decision. In all 50 states and DC, healthcare providers must report any suspicion of abuse to authorities. That means that you don't have to have proof, you just have to have a suspicion. It's not up to you to decide if the person's guilty or not. You just need to report it to social services. It's their job to determine if something's happened. Let's talk about pediatric differences and how these differences will impact your nursing care. First of all, pediatric patients have tongues that are larger in comparison to the size of their oral cavity, which increases their risk for airway obstruction. So it also can make it more difficult to intubate. They have a trachea that is shorter and narrower. They have cartilage that is more elastic and collapses easily. This is why they are prone to something like tracheomalacia or laryngomalacia, because their cartilage is so much more elastic. And this is also why you need to vary your technique when you open the airway of a pediatric patient. Their head should be in a neutral position with their neck slightly extended. Younger children have a larger proportion of soft tissue in their airway, which makes them susceptible to swelling from edema and inflammation from foreign objects, allergic reactions, bacterial or viral infections. So this is one of the reasons why a bacterial or viral infection in a pediatric patient is so much more serious, or can be so much more serious, than in an older child or an adolescent. And also, newborns are up to 2 to 4 months of life are obligate nose breathers, meaning they do not breathe out of their mouth at all. So if you're taking care of a pediatric patient that has a stuffy nose, it's going to cause them respiratory distress. And one of your priorities needs to be to make sure that you clear that nose, either with the bulb syringe, or if it's significantly obstructed, with deep suctioning, so that you can make sure they have a clear airway. Pediatric patients also have heads that are larger than the rest of their body in proportion, and they become more adolescent or adult-like by adolescence. This means that during a fall, or mechanisms when a child is thrown, like from a car, the body acts as a missile with the head leading the way, and this is why they have a high incidence of head trauma. So if you have a pediatric patient that's fallen from a balcony, they're going to land head first, every time. Greater body surface area to total body weight than an adult, which makes them more prone to hypothermia, more able to lose body heat and water through the surface of their skin, so they're more prone to dehydration. And it also means that if you're in a situation where you have to immobilize their airway, you may need padding under their shoulders. Pediatric patients have a weaker abdominal muscles, causing the appearance of the abdomen to be distended. So that's why they have a little Pooh Bear belly, especially in toddlers. They also have liver and spleen are lower and more anterior, so they're not as protected by the rib cage. This means that if there is a trauma situation, the ribs do not provide protection in the same way they do as an adult, and this is one of the reasons why trauma to the abdomen in a pediatric patient can lead to severe organ damage. Children are abdominal or diaphragmatic breathers until they're 8 years of age, meaning that you can look at a child until the age of 8 and count their respirations really by looking at their abdomen. So you need to make sure that you avoid any restrictions or restraints over the abdomen so a child can breathe easily, especially when packing a child for transport. So you would not want to have, for example, straps tight over a pediatric patient when you're transporting them, because that's going to impact their ability to breathe, and you, in the same way that you wouldn't want to have like an abdominal binder that you could find in an adult. You don't find those in pediatrics. Their airways are narrower and they're smaller. The narrowest point of their airway is at the cricoid cartilage, but in the adult it's at the level of the vocal cords. This means that pediatric patients are more prone to obstruction when their airways get congested with fluid, mucus, or secretions. Newborns have 2 fontanelles. The anterior closes between 10 and 16 months, and the posterior closes between birth and 3 months. Assessment of the anterior fontanelle can indicate dehydration or increased intracranial pressure. The anterior fontanelle obviously is the one in the front, and they love asking that on the NCLEX. The thoracic cavity or chest wall is softer and more compliant. Rib fractures are not common, but they also provide minimal protection to the underlying organs and blood vessels within the cavity, which we've already touched on. When you assess the anterior fontanelle of an infant, they should always be assessed sitting upright and not crying. A firm or bulging fontanelle may indicate increased intracranial pressure. Crying may also cause bulging. A sudden or depressed fontanelle may be the result of dehydration. Because of the small size of the chest and lack of musculature, breath sounds in infants are easily transmitted through the chest. You should oscillate breath sounds at the mid-axillary line bilaterally. So in the middle of the chest, right around the sternum, is where you want to oscillate breath sounds. This slide shows examples of normal pediatric vital signs. You will note there's a big difference between what is normal for the newborn and what is normal for the adolescent. And if you take care of pediatric patients, you do need to have these memorized. If you don't know what's normal, you cannot identify what's abnormal. I will provide, for our trip to Morgantown, a little cheat sheet with pediatric vital signs for your reference. In continuing with the differences in pediatric patients versus adults, you should know that pediatric patients have a high metabolic rate, higher than adults, and they require more energy and consume more oxygen as a result. Their illness and stress accelerates metabolic rate even further. This makes pediatric patients prone to hypoxia. You need to always provide a high oxygen environment for critically ill or injured children. Because of the bigger body surface area and the higher metabolic rate, children and pediatric patients need higher fluid requirements. A newborn's total body weight is 70 to 80% water. Adults are only 50 to 60%. This means they're more prone to dehydration when there's increased fluid loss due to diarrhea, vomiting, or conditions that increase metabolic rate, like a fever. You should know that the total circulating blood volume per unit of body weight is greater than adult by 25%, and it can be estimated at 80 to 90 milliliters per kilogram. Meaning, if you have a 10 kilogram child, the estimated blood volume of that child is 900 milliliters. This is important to remember when you are taking blood from a child, and we're going to go over the general rule for that, but I'm going to mention it here. And the general rule is that you can take 1/1000th of the total blood volume. So if you have a patient that is 10 kilograms, you can take 10 milliliters, excuse me, of blood from that patient a day. If you have a patient that's 40 kilograms, you can take up to 40 milliliters of blood from that patient a day. That's a general rule of thumb. I emphasize this because I think you need to know when we're replacing IV fluids in a pediatric patient, you need to know that 1 kilogram of weight loss is replaced by 1 liter of fluids. And you can estimate the water deficit by figuring out the percent of weight lost. For infants, it's mild weight loss or mild dehydration is less than 5%. Moderate is 5 to 10% of weight loss, and severe is over 10%. And in older children, mild dehydration is less than 3%. Moderate dehydration is 3 to 6%, and severe is greater than 6%. And you calculate that, just for your knowledge, by taking the child's healthy weight, their known healthy weight, and finding their sick weight, and subtracting their sick weight from their healthy weight. For example, if you had a child that was that is currently 9 kilograms, but was 10 kilograms at their child visit, you would subtract 9 from 10, and that would give you a weight loss of 1 kilogram. In order to figure out the percentage, you need to take that weight loss of 1 kilogram and divide it by the child's healthy weight. So it would be 1 kilogram divided by 10, and that's 0.10. And in order to figure out the percentage, you would multiply that by 100. And I will have some examples of how to figure out percent weight loss attached to these slides. Basically, it's the same formula for figuring out what percentage that Coach purse is on sale. It's the same calculation. It's just substituting weight loss instead of sale prices. When you have pediatric fluid therapy, you need to keep in mind that IV bolus for a child is always 10 to 20 milliliters per kilogram, and it's usually 20 milliliters per kilogram. And that it's going to be normal saline or lactated ringer. Remember, you never want to bolus potassium unless you are working on death row, because you will kill your patient. You can repeat up to 3 boluses. Generally, pediatricians will replace half of the deficit over 8 hours and the other half over 16 hours. This is a crucial formula for figuring out IV fluid calculations for pediatrics. It's used universally. If you go to Australia, this formula will be used. If you go to China, this formula will be used. So it's really important that you know it, because you're going to have a physician order fluids, and you need to know if they're appropriate for your patient. If you have a patient between 0 and 10 kilograms, they have a daily fluid requirement of 100 milliliters per kilogram per day. This is just to maintain their hydration. This is not what the physician would order if the patient was dehydrated. This is just maintenance. If you have a patient between 10 to 20 kilograms, the physician will order 1,000 milliliters plus 50 milliliters per kilogram per day for every kilogram above 10. So in this case, if you have a patient that is 15 kilograms, you're going to be giving that patient 1,000 milliliters plus 50 milliliters per kilogram for every kilogram above 10. So that would be 5. There's 15 is 5 kilograms more than 10. So you would take 1,000 milliliters plus 50 times 5, and that would end up being 1,250 milliliters. And that is your daily requirement for your patient. For a patient between 20 to 70 kilograms, the daily requirement is 1,500 milliliters plus 20 milliliters for every kilogram per day for every kilogram above 20. So if you have a patient here that is 40 kilograms, you start with a 1,500 milliliter requirement, and then you take 20 milliliters for every kilogram above 20. So 40 is 20 kilograms above 20, so you take 1,500 plus 20 times 20, and that would be 1,900 milliliters. Keep in mind always that this is a daily fluid requirement. In order to figure out what an hourly rate would be, you would need to divide that by 24, the hours in the day. Finally, on any patient above 70 kilograms, the physician will order 2,500 milliliters per day, and that is a adult requirement. The usual bolus of dextrose is 2 milliliters per kilogram, and it can be given IV push, and you never want to give more than 10% IV in a peripheral line. So for example, if you have a pediatric patient that's 10 kilograms, the physician will order 20 milliliters of D10 IV push if you have a patient with low blood sugar. In taking care of a patient, a pediatric patient, you need to assess them when the child is quiet and laying down, helpful if their knees are bent. Distracting a child may be necessary since they tense their abdominal muscles if they anticipate your approach. When you're checking a child's perfusion, the child's skin should be warm near the wrist and ankles. When you check their capillary refill at the kneecap or forearm, you should note normal refilling time is less than 2 to 3 seconds. You need to know that fever greatly affects the pediatric patient. It increases fluid requirements by 12% for every degree in Celsius of fever. So if you have a patient that has 104 temperature, that is 6 degrees Celsius over baseline, and they would end up needing fluid requirement of more than 72. I'm sorry, I'm doing that in Fahrenheit when it says clearly right here it's Celsius. So if you have a patient that is 38 degrees Celsius, that's 2 degrees over their baseline, what their baseline should be. So they would have an increase of 24% in fluid requirement. Keep in mind also that every degree of fever, and this is Fahrenheit, raises the heart rate 8 to 10 degrees, or 8 to 10 beats per minute. And finally, Every degree of fever raises the respiratory rate by 4 breaths per minute. So if you have a pediatric patient that's tachycardic or tachypnic, just administering Tylenol and or Motrin and getting that fever under control is going to help your patient tremendously. You also need to remember that a fever of 100.4 or more in a child less than 3 months of age is an automatic sepsis workup. Automatic. And involved in that sepsis workup is blood culture, CBC, BMP or CMP, a urinalysis and urine culture, and if nothing shows up, they will also do a lumbar puncture. Also keep in mind when you're doing blood cultures or even a lumbar puncture to get cerebrospinal fluid culture that you want the patient to continue to have a fever as long as it's not, dangerously high. It is easier to catch the bacteria when they're more mobile, when the patient is febrile. In general, you can estimate pediatric patients' blood pressure by the following calculation. A minimum blood pressure of 70 plus 2 times their age in years. And this should be on a separate line. So for example, if you have a patient that's 10 years old, they should have a blood pressure of 70 plus 2 times 10. So 90. That's their minimum systolic blood pressure. Infants double their birth weight by 5 months. They triple their birth weight by 1 year. In older children, their weight in kilograms is approximately equal to 8 plus 2 times their age in year. You need to always keep in mind that vital signs are often an unreliable indicator of a child's true condition. They vary greatly with age, body temperature, and anxiety. Chad, we'll go somewhere else to do that. They may be difficult to obtain due to constant motion, the agitation, and resistance of a child. Always trust yourself. If you feel that child is sick, the child is sick. It does not matter what the vital signs say. If your assessment shows that they're sick, they're sick. And stick to your guns if the physician thinks otherwise. If you really believe that they are ill, then you need to advocate for your patient. Let me back up. For younger children and infants, heart rates are easier to obtain by palpating the brachial pulse or oscillating the apical pulse in the area of the left nipple. For older children, heart rates are obtained the same as adults. Take the rate for 15 seconds and multiply by 4 in emergency situations. Irregular rates may be taken for 30 seconds and multiplied by 2. Tachycardia is usually caused by hypoxia, fever, acute infection, anxiety, and can be an early sign of shock. Each degree of fever raises the heart rate 8 to 10 beats per minute. That's a repeat, but I thought it was worth repeating. Bradycardias can be due to critical hypoxia or ischemia. Respiratory rate. When you're assessing respiratory rate in a child less than 8 years old, again, observe abdominal movement for respiratory rates. Alternatively, you can place your hand on the back or abdomen while counting the rate or oscillating the rate with a stethoscope. To attain a respiratory rate, count the number of respirations for 30 seconds and multiply by 2. Hyperventilation may be due to hypoxia, fever, pain, anxiety, or excitement. Again, fever. Each degree of fever raises the respiratory rate by 4 breaths per minute. Hypoventilation may be a result of drug overdose, severe head injury, exhaustion from labored breathing. When you take the blood pressure for a pediatric patient, you need to make sure that you're using an appropriate cuff size. The width of the cuff should be approximately 2/3 the length of the arm between the shoulder and the elbow. It is often very difficult to obtain a blood pressure in a child less than 3 years old, and should only be attempted if the child is critically injured. But it should be attempted if the child is critically ill or injured. Remember, hypotension is almost always a late sign of shock in children. Hypertension is very uncommon. It's not a clinical problem for children in the field. It is sometimes a problem for children with sickle cell anemia. Okay, now that you know some differences in your pediatric and adult patients, I'd like to talk to you about how to determine if your child is ill. We're going to talk today about the Pediatric Assessment Triangle. It's a universally used tool and to determine how sick your child is. The old adage is, do you stay or do you play? Do they stay in the ER or can they go home and play? There's 3 parts of the Pediatric Assessment Triangle. You have appearance, breathing, circulation, or skin color. Appearance is, let's see, we're going to go back into it in a minute. So today this is a slideshow that I got from the internet, but we're going to go over this, and then I did add some slides to it just for your information. But we're going to find out today about using the Pediatric Assessment Triangle, or PAT, to determine the severity, physiologic abnormality, and urgency for treatment. And we're going to discuss some key developmental characteristics for different age groups, employ special assessment techniques, and integrate the Pediatric Assessment Triangle with age-appropriate assessment. The Pediatric Assessment Triangle is an observational assessment only. You do not need any tools to perform this assessment. You only need yourself, your senses, your eyes, your ears, your brain. No stethoscope, no instruments, nothing is involved except you. It gives you a great first impression of that child, and it can be utilized within 10 to 20 seconds of first meeting a child. It establishes the severity of illness or injury for you, and it determines the urgency of interventions. Also identifies the general category of the physiologic abnormality. Here is a slide detailing the Pediatric Assessment Triangle in more depth. Again, we have work of breathing, circulation to skin, and appearance. Unlike what you normally think of as appearance in the Pediatric Assessment Triangle is more the interactiveness of the child with his or her environment. And there's a mnemonic to help you remember that called TICKLES. And that stands for tone. Do they move spontaneously? Do they resist exam? Are they flexed or extended? Interactiveness. Do they appear alert and engaged? Are they well enough to be afraid of you? If they're letting you do whatever you want to them, you need to be worried. Consolability. Do they stop crying when holding or comforted by the caregiver? Do they have different responses to the caregiver or the examiner? If they don't, again, if a child is letting you do whatever they want to them, you need to be worried. Look, gaze. Do they make eye contact with the clinician? Do they track what you're doing? Speech, cry. Do they use age-appropriate speech? Excuse me. So again, appearance is TICKLES. Tone, interactiveness, consolability, look or gaze, speech or cry. The second part of the triangle is work of breathing. That's more self-explanatory. You consider abnormal airway sounds. Are they snoring? Do they have a muffled, hoarse speech? Is there any stridor? Are they grunting or wheezing? Do they have abnormal positioning? Are they in a sniffing position? Are they tripoding, meaning are they sitting forward with their arms on their legs in a manner that is trying to expand their lungs? Do they have retractions? Are they supraclavicular retractions, intercostal retractions, substernal retractions, or even head bombing in infants? And is there any flaring of the nares on inspiration? And flaring, if you recall, it looks like the child is taking a big whiff of, something, and their nares really flare out. And then the third part of the pediatric assessment triangle is circulation. And within circulation you have pallor. Are they white or pale? In dark-skinned children, they may be gray. Mottling. Do they have patchy skin discoloration due to their variable vasoconstriction of their veins? And cyanosis. Do they have bluish discoloration of their skin or mucous membranes? And that could be acrocyanosis, just in their extremities, or circumoral cyanosis, just around their mouth, or it could be overall. And keep in mind, with dark-skinned children, it is easier to determine cyanosis if you look inside their mouth, at their mucous membranes, especially. This chart here is a great cheat sheet in determining how sick a child is. You can see if you have a presentation for the child, when you take a look at the child, their appearance is normal, their work of breathing is normal, their circulation to the skin is normal, you have a stable patient. If you have a patient that has a normal appearance but abnormal work of breathing and normal circulation, you have a child in respiratory distress. And there are management priorities listed here for that child. If you have a child that has an abnormal work of breathing, an abnormal appearance, and a normal or abnormal circulation, you have a patient that in respiratory failure, decompensated shock, or cardiopulmonary failure or arrest, and so forth. Shock that's compensated, you have a normal appearance, or normal work of breathing, and an abnormal circulation to the skin. And a metabolic dysfunction, such as brain injury or like a shock failure, you will have an abnormal appearance, but you may still have a normal work of breathing and a normal circulation. And I'm going to provide this along with the vital signs cheat sheet for your use when we go to Morgantown. Let's take a look at an example of a child using the pediatric assessment triangle for diagnosis that has a normal appearance, normal circulation, but an increased work of breathing. Oh, I'm sorry. I got those slides in the wrong order. So that would be respiratory distress. And I just went over that, but we'll just go over it again. Respiratory failure, you have abnormal appearance, normal or abnormal circulation, and an increased or decreased work of breathing. It's important to remember, in respiratory failure, the patient may have progressed to the point where they're not having an increased work of breathing anymore, they're having a decreased work of breathing. There's barely any respirations at all. Shock. You have the appearance of being abnormal, circulation to the skin is abnormal, but you may have a normal work of breathing. When you have primary central nervous system dysfunction or metabolic abnormality, you have an abnormal appearance, normal circulation of the skin, and a normal work of breathing. Here's a case study when we're talking about a 2-week-old infant. You are called to the home of a 2-week-old infant, and this is for EMTs, but this applies to the ER nurse or to the nurse on the floor that just has had a patient sent up from the ER. You're called to the home of a 2-week-old infant who has stopped breathing. The infant's turned pale, limp, revived when sitter blew in her face. It was a term delivery with no complications. The patient has had 2 days of poor feeding, but no fever. In this scenario, we have a patient with appearance, eyes open, they're moving their arms and legs, they have a strong cry, so they have a normal appearance. They have an abnormal work of breathing. Their abdomen rises and falls with each breath, so that sounds, I guess, like they actually have a normal work of breathing. And then circulation to their skin, they have face and trunk normal, but their hands and feet are blue. What do you think of this baby's work of breathing? Are you concerned about her skin signs? Belly breathing reflects increased reliance on the diaphragm. Acrocyanosis reflects poor peripheral vasomotor control. These are normal findings in an infant less than 2 months of age. So going back, that was a little bit me tricking you here when I said that there was abnormal circulation. I wanted to see if you picked up that it was just the hands and feet that are blue in a 2-week-old infant. Okay. So is this baby's appearance normal? Yes, it is. Should you transport, in this situation, the baby turned blue, then probably would still be admitted to the hospital. In infants less than 2 months of age, you need to be aware that it can be difficult to tell if their appearance is normal or not, because they have limited behavioral repertoire. They're only awake for brief periods. They generally don't make eye contact or track faces. They generally don't have a social smile, and until they're about 2 months of age, they generally don't show signs of recognizing parents versus strangers. So you need to treat based on their age and their history. In taking care of an infant 2 to 6 months of age, you should recognize that they start having a social smile. They do recognize caregivers. They track light and faces. They have a strong cry and increasing vocalization. They can roll over and sit with support. A normal appearing infant from 6 to 12 months of age is socially interactive. They're going to have separation or stranger anxiety. They can sit without support. They play with toys and put everything in their mouth. They have increased mobility. They may even be walking by 12 months of age. And they babble. When examining an infant, you can examine them in any location. You just need to use a soothing voice and offer distractions. Keep your hands and instruments warm, and always examine the chest and abdomen first. In examining or assessing an infant greater than 6 months of age, you should anticipate that they're going to have separation anxiety. Examine that child on the caregiver's lap. Sit or squat to make yourself smaller. Or offer toys and distractions, and take a toe-to-head approach. You start at the extremities and you work your way up. And that was supposed to be a pediatric core case for you to watch, but the link is not here. I'm going to see if we can watch it afterwards. Hold on, let me see. I'm going to take it and do it this way. Note the severe retractions. This baby is using all their accessory muscles to breathe. Their appearance is abnormal. So just in that case, if you just change their position to a better sniffing position, that really helped that child's work of breathing. Okay. You have a 23-month-old toddler. Let's say that you were called to the home of a 23-month infant with trouble breathing. The child is on the mom's lap, sees you, and starts to wail. The patient is alert, with retractions and audible wheezing. Their skin color is normal. What can we tell from the pediatric assessment triangle? Their appearance: they have a seated, alert, strong cry. They work of breathing. They have retractions and audible wheezing. Circulation: they have normal color. So they are in respiratory distress. As you approach, the child yells, "Go away!" and tries to hit, kick, and bite you. Is this a normal appearance? What are the expected behaviors of a toddler? This is very normal for a toddler. Assessment of a toddler. The terrible twos last from 1 to 3 years of age and are characterized by lots of mobility. They are on the run. Curiosity. They have absolutely no fear of danger. They have very strong opinions. They have stranger anxiety and separation anxiety and egocentrism, meaning they cannot see others' point of view. They only see their point of view. Assessment of toddlers. Toddlers are concrete thinkers. They problem solve by trial and error. They have a limited ability to anticipate consequences. They are not swayed by logic. They have variable language capabilities, and their comprehension is greater than their expressions. They understand more about what's going on than they can communicate. When you are assessing a toddler, it's great to be able, when you can assess them from across the room, allowing the child to remain in their caregiver's lap. Always get down to the child's level and use play and distraction. Talk, reassure, and praise the child. Use funny voices. Be silly. Explain the procedure simply. Do a toe-to-head exam. Save the worst part of the exam for last. And enlist the caregiver's assistance. You recognize that this toddler's continued agitation, despite attempts to reassure and distract him, is developmentally normal. But would crying and fighting be a normal response in a 6-year-old with respiratory distress? We're going to watch another shock scenario case. This child has an abnormal appearance, an abnormal work of breathing, and abnormal circulation. Therefore, they are either in respiratory failure, cardiopulmonary failure, or shock uncompensated. What is the normal appearance of a child 4 to 10 years of age? They're very mobile, independent, they take risks, they have good verbal skills, they're analytical, they understand cause and effect. This is the age of reason. They want to know why, how things work. They're cooperative with exam and instructions in general, but they have many misconceptions about their bodies. They may overestimate implications of illness or injury. They have a fear of pain, deformity, and needles. They may misinterpret information given, and their independence may crumble when they're sick. So they revert to an earlier stage in their development when they're sick. You should always speak directly to a child in this age group, provide simple and clear instructions, anticipate their questions and their fears, and praise cooperation, avoid ridicule. You want to provide a sense of control, but don't negotiate. Examine head to toe and respect their modesty. Minimize lag time between describing and performing procedures. If talking fails, restrain in order to ensure their safety. Again, this child has an abnormal appearance, abnormal work of breathing, and abnormal circulation. You can see the modeling here. Delayed cap refill. Okay, sorry, I'm trying to exit here. Go back to our PowerPoint slides. You have a 16-year-old adolescent. You're called to the scene of a 16-year-old who rolled his Jeep. The patient is standing by the car on your arrival and is intoxicated, alert, and hostile. He starts to cry when realizing he's bleeding from his scalp, asking you, "Am I going to die?" You have a normal appearance, a normal circulation of the skin, and a normal work of breathing. Is this young man's appearance normal? Yes. What are the special challenges you face in assessing an adolescent? Adolescents and toddlers share a lot of the same characteristics. They're very mobile, they're risk-taking, they have no fear of danger, they have a limited ability to anticipate consequences, and they are not swayed by common sense. Adolescents do have a capacity for rational thought and analysis. Their dependence shifts from family to peers. They often fear a loss of control or disfigurement or being different, and they may misperceive the severity of their illness. Talk to the teen, not to the parents. Respect their privacy and confidentiality. Provide concrete explanations. Reassure, but do not succumb to provocation. Here's a patient with adolescent with a whooping cough. I'm going to fast forward a little bit here.
What do you need, bud?
Okay. It takes a little while for you to see this child's in just stress. I thought I had gotten to the right part in the video. Alright, let me back up a little bit. Here we go.
Breathe through your nose. Breathe. Breathe.
Slow. Oh, slow.
Breathe. Nose. Nose. Nose.
So, even though that child has extremely annoying mom, in that case, it may be a little bit of not the best video, but the child was obviously in respiratory distress. He had a normal appearance, normal circulation, but he was having difficulty breathing, and that was from the whooping cough or pertussis. You're called to a daycare center to see an 8-year-old who is not acting right. He has a genetic syndrome with multiple birth defects and has a VP shunt, a gastrostomy tube, and scars from recent spinal fusion. The patient has multiple anticonvulsants, cardiac, and pulmonary medications. He has his eyes open, random gaze. He's contracted with no movement. His circulation to his skin is mottled. He has loud, gurgling, work of breathing with moderate retractions. When you're assessing a child with special health care needs, you always need to enlist the assistance of the caregiver in order to determine what is their baseline functional status, what's their baseline medical status, and what kind of threshold do they have for transporting. In conclusion, knowledge of normal child development enhances your ability to recognize abnormal appearance. The use of age-appropriate assessment techniques maximizes history and exam information. Children with special health care needs offer a unique challenge. I'm going to stop here and make this into a second video.